Welcome to this edition of Lightning Reports, an accredited continuing education activity. This brief expert video will spotlight the daily hot topics from the conference. Instructions for receiving continuing education credit will be provided after participating in this activity.
Hi, my name is Dan Pollyea, and I'm a professor of medicine in the Hematology division at the University of Colorado School of Medicine. Thanks so much for joining us today for episode 1 of the Lightning Reports from the 2022 ASH annual meeting on low-risk MDS. So we're very excited to focus on low-risk MDS because I think we all have begun to recognize in the last couple of years that there are many, many differences in low-risk MDS versus higher-risk MDS, and that drug development really needs to focus on each of these entities separately. Higher-risk MDS has some encouraging randomized phase 3 clinical trials that are ongoing right now, and we are waiting anxiously for those results. And in the meantime, I think we need to take other strategies to focus on the lower risk MDS population. And so I've chosen to talk about several of the clinical trials that were presented at this year's ASH meeting that do just that focus on the low risk MDS population. The first is abstract 459. The drug here is Imetelstat, and Imetelstat is a really novel therapy that is a telomerase inhibitor. And this is felt to be potentially important in patients with MDS for a variety of reasons. There was a phase 2 study that was ongoing using Imetelstat in a low-risk patient population, and the investigators noted that a certain subset of these patients had particularly good clinical results. And so they did sort of a longer-term follow-up of this subset of patients. Specifically, these are patients who were non-deletion 5q MDS and had not had lenalidomide or an HMA. And so, really received Imetelstat in the very early course of their disease. And, what they found was that there was a substantial number of these patients who had long-term transfusion independence. So this subset was about 38 of 57 patients. And of those 38 patients, 30% of them had greater than a year of sustained transfusion independence. And that's really notable, for this patient population, and I think very encouraging. And I think this is what we need to keep doing in the field, is finding these subsets of patients that respond to particular treatments and kind of picking them off to apply these particular targeted therapies, and then continuing to do that for all patients. So I think that's going to be the way forward, is finding patients with MDS who have unique sensitivities to particular therapies that we have. So really encouraging that there is a subset of patients that seems to respond so well to Imetelstat, and adding to that to luspatercept, which we also have now, I think is a very hopeful sign. The next clinical trial I want to talk about is abstract 461, and this involves a drug that was relatively recently approved for MDS. This is the oral formulation of decitabine, and it comes packaged together with another therapy that helps prevent it from being degraded in the GI tract. So it allows it to be an oral therapy. And we have data now that this is completely equivalent to conventional or intravenous decitabine. So it's approved across the board in every way that decitabine is approved. But the investigators here thought, the one-size-fits-all dose and schedule of an HMA probably is not ideal for this disease, and there may be different needs for different types of MDS. So higher risk MDS patients, maybe they need a different dosing schedule than lower risk MDS patients. So that's what this study was, essentially a phase 1 study to look at different dose cohorts of oral decitabine in specifically low-risk MDS patients. And about 50 patients were treated in multiple different dosing cohorts, looking at all different sorts of efficacy and toxicity endpoints. And in fact, what was decided was that The dose and schedule that was sort of felt to be the best from a safety and efficacy profile was 10 milligrams of decitabine with 100 milligrams of this companion drug for 5 days in a 28-day cycle. And so that's sort of what has been moved forward into an ongoing phase 2 study for this population. But it's, I think, very notable that these, different risk profiles of MDS are appropriately being regarded differently and being treated differently. So that's, I think, hopeful news for the future. The third clinical trial I wanted to discuss is abstract 457, and this uses Ruxolitinib, the well-known JAK2 inhibitor, in an MDS subtype called chronic myelomonocytic leukemia, or CMML. So CMML is a subtype of MDS, as I said, but it's also the classic MDS-MPN overlap condition, MPN being myeloproliferative neoplasm. And people who have pure MPNs, we know have clinical benefit from Ruxolitinib. It's FDA approved for this purpose. We also know that Ruxolitinib, while it definitely has some efficacy, clinical efficacy with respect to traditional time points like responses and survival, it also makes patients feel better. And it does that because it helps to shrink their spleens, which can be very symptomatic in these diseases. And it also helps just general fatigue and other sort of more systemic symptoms that occur from these diseases. These investigators ran a relatively small phase 2 study looking at Ruxolitinib in about 29 patients with chronic myelomonocytic leukemia. And they had a lot of different endpoints. There was some traditional efficacy with a response rate of about 20% in this small study, which is fine, good. But also importantly, there was a significant number of patients who had really very notable spleen shrinkage. So about 30% had greater than 35% of their spleen volume reduced before, pre and post treatment. And then another large percentage of patients had a little bit of a lesser spleen shrinkage that was notable. And then also very importantly, with some surveys used for quality of life purposes, there was really almost universal improvement in some of the systemic symptoms associated with CMML. So a lot of good reasons to think about Ruxolitinib in this disease where we don't really have any specific therapies that are notable right now. And then finally, I want to talk about a non-clinical trial, but one that will help the entire field. This is abstract 465. This was an external validation of the new IPSS-M. So we've long had IPSS risk prognosticators in the field of MDS, starting in the 1990s, going into revisions using more granular clinical data. And then within this last year, the IPSS-M, which incorporates molecular data or gene mutations. So this is a great tool. Everyone should be using it in their clinical practice. And so the folks at Moffitt said, well, we're going to take our 2,000 patients and do an external validation of this scoring system. And fortunately, it all looks very good. It reads out very nicely. Essentially, they were able to externally validate this and show that, yes, in fact, the different groups that were predicted by the IPSS-M do in fact exist in the Moffitt data set. And so I think we can have even more confidence in this tool using it for our patients. And it's very important to be able to have a good risk stratification system for MDS. So thanks again for joining us for this ASH Lightning Report on low-risk MDS, and be sure to join us again for episode 2 from ASH 2022 on high-risk MDS, and check out the activity page to view the downloadable slides. Thanks so much.
We hope you found this activity useful and educational. To receive continuing education credit and to download your printable certificate, please return to the activity webpage and click on the Claim Credit button associated with today's report. Your certificate will be available to print upon successful completion of the brief post-test and evaluation.